The challenge, there is no solution. So let us start first with the challenges. In cardiovascular disease, it is a chronic disease. So there is no one single factor. Therefore, we should have some factors which can be blamed that probably it causes cardiovascular disease. And these are called as risk factors, whereas studies epidemiology. Epidemiology changes from time to time. Early detection of risk factor is very important for prevention of the disease. And this is, as rightly said by my chairperson, prevention is the best medicine even for the chronic diseases, including the cardiovascular disease. How to control risk factors? Few we can control, which are called as modifiable. Few we cannot control, such as the age of the person, gender of the person, family history. These are called as non-modifiable risk factors. Solutions. Various guidelines prop up every time. Recently in 2013 and 14, we are having all the guidelines which has been revised, which helps us in monitoring the patient. But for Indian scenario, for the compliance of the patient is very important. And for this, we require simple dosing regimen, which is the focus of this talk. As you all know, chronic disease is increasing, so this coronary heart disease, it was 11, now it is 14%. It is increasing along with the diabetes. It is not only increasing, but it is increasing the mortality associated with the cardiovascular disease. It affects the family, it affects the nation, and it poses a huge financial burden both on family and the nation. I shall just read out the conclusion of this paper. There is a disturbing burden of cardiovascular disease on Indian population. There is an urgent need to undertake population-based measures which are preventive measures. One-to-one treatment cannot solve this chronic disease. These are the various risk factors which we all know, traditional risk factors which are continuing since last many decades, which you all know: increase in the cholesterol level in the blood, diabetes mellitus, hypertension, family history, age of the person, gender of the person, visceral obesity, metabolic syndrome which has been now added, use of tobacco, both smoking as well as chewable, and there are certain emerging risk factors in which the inflammation is also blamed. Sometimes it is said that a tooth infection can lead to heart attack. Even I am a sufferer of that. Half of the urban Indians, they are not satisfied with their weight and figure. Tobacco use, very common. This city is famous for tobacco, and you will be surprised to know that India is the 6th largest producer and exporter of tobacco. Psychosocial factors, because of the nuclear families, workplace, etc. Physical inactivity in the Indians is a very common. Indians walk very less as compared to their global counterparts, and live with abnormality. Urbanization and industrialization is very good for us. It gives us how to live more comfortably, but simultaneously it brings the chronic diseases also. Automobile industrialization leads to inactivity. Changing dietary pattern. You will be surprised to know that McDonald's, KFC, it is the food of poor for America, but it is food for rich in India. Indians, those who are rich, those who are literate, they have got the poor choice of food. And this is not only used in between the meals. We are having the habit of taking 3 meals. And this dietary shift is causing lot of disease damage, diabetes, abdominal obesity, etc. And you all know in 3 Idiots, there was a dialogue. एम्बुलेंस 30 मिनट में नहीं आ सकती है, पिज्जा जरूर आ जाएगा. So what should we do? We should, if we want to prevent the disease or if we want to tackle the disease, we have to detect the risk factors and then we have to monitor it and then treat it also. First is the recognition. It differs from country to country, but there are certain common risk factors. So one has to recognize what are the risk factors prevalent in that particular area. Then define the optimal treatment for that. Then use the aggressive medical therapy if that particular risk factor requires medicine, such as the hypertension control, diabetes control, control of high lipids and blood thinner agents. You will try to halt the progression of the cholesterol buildup in the arteries, which are the common culprit for ischemic heart disease. The top of the pyramid is the treatment part. It cannot be afforded by many in this country. The reason is very simple. Medical insurance is not popular. Everyone has to bear the cost of the medicine from their own pocket. Therefore, the base of the pyramid is very important. You have to approach the population, and in this matter, the physician sitting here will be of more use, not the specialist. So, what should we do to control the risk factors? We can advise for the changes in the lifestyle, which is very important, and taking the medicines where there is a comorbid condition is there. These are the various clusters which I have already mentioned: lipids, obesity, hypertension, and that can lead to the cardiovascular disease. Treatment strategy is simple. You have to modify the lifestyle of the person. You have to encourage the person to go for the physical activity, quit the tobacco, antiplatelet, statin, antihypertensive where it is needed, and treatment of other comorbid conditions. Aspirin is the wonder drug for heart disease. But when it was discovered, it was written on the bottle, it does not affect the heart. It is only a painkiller. But now it is the drug which has to be given to all cardiac patients for secondary prevention unless contraindicated. So, task force recommends recently that aspirin should be used both in the primary and secondary prevention. This is the latest guideline, various lipid agents which are used for high intensity, moderate intensity and low intensity lipid therapy. And we have to take care of the hypertension. These 3 are the major risk factors. We have to tackle it, and how we should tackle it. There are medicines and there are lifestyle modification strategies. We are very wise. We know all those things. We know the risk factor, we know the treatment. Even the failure rate is very high. What is the cause? Patients say, physicians don't devote time to us. We blame patients, their apathetic approach. But this blame game is not going to solve the problem. Physicians should be wise enough to know what are the various guidelines, what are the various dosing schedules, what can be afforded by the patient. Patient should know how to take, they should be aware of the disease, they should be made knowledgeable, if not by the physician, but then by the paramedical staff. This is for the best of the treatment. Before this, I am telling you one thing. Major hospitals of India I'm talking of teaching hospitals, not the district hospitals. Blood pressure is measured only in the medicine OPD and cardiology. Rest of the OPDs, they don't have blood pressure instrument. This is a very pathetic approach from our side. So we should not always blame the patient population. Even in Western countries, only half of the patients who are hypertensive, they are taking treatment properly and they are controlled to the target level. In one of the Chennai study, half of the patients were diagnosed to having hypertension. Only half of them received treatment. And out of those who received treatment, only half they are near the control. So this comes to 10% only. This is for the urban population. You can imagine what is the burden of the disease in the rural population. So we come to the solution now. What are we should know the guidelines. Physician must know what are the various guidelines which are helpful in that ethnic group, which is helpful for their population. So implementation of guidelines is very important, but even the scenario is not good. This is for the whole of the world, this is data. You can find that various drugs which are mandatory for the primary and secondary prevention of heart disease are only prescribed or taken less than 1/3 population. For the guidelines also, this is from the European physicians, they follow their own guidelines. They are less aware of the guidelines which are prevalent. We in India usually follow the American guidelines. So, we should not always blame to the patients for their compliance, loss of compliance, or for apathy. The lack of appropriate medication therapy, intensification by clinicians is a primary reason that patients fail to reach recommended targets for condition for all the chronic diseases. So we should also know what are the drugs, what are the target levels for their patient. So compliance and adherence is the basic thing where we fail in delivering the best possible treatment to our patient. And this has to be addressed properly. We know there are hurdles in India, patient illiteracy is there, apathy is there, awareness is not there, ignorance is there. But we as physicians, we have got good drugs, good devices, but we are not able to extract the best possible result by that. Common chronic diseases, the basic thing is, since majority of the patient is asymptomatic. In hypertension, only 10% of patients get symptoms. Diabetes, only 20% get. So this is one of the basic reasons, and for this awareness and knowledge is more important. What are the various points where we can increase the adherence and the compliance? Socioeconomic. Elderly patient, because of the financial reason, because of the depression or forgetfulness, they usually leave their drug. Patient relative, I have already told. Therapy related, in making his life, we are very conscious that we should not be blamed. It should have been written the physician related. Because complexity of the regimen is done by the physicians, not by the therapy related. Duration of the treatment, again we have to say how much we have to take, how many days we have to take. We have to give a certain knowledge for the side effects and the adverse effects. And if we are changing the therapy, we should tell why we are changing the therapy. Then it is the condition related, what are the various drugs, what are the various diseases, what is the severity of the disease. And then the healthcare system is very important. I know many physicians, waiting time is on an average 2 hours. You don't have time to give sufficient time to your patient. Here comes the role of paramedics, and they should educate the patient in every clinic. And for this, I hope the print media and electronic media should also help. So if we tackle all those issues, then probably we can prevent the disease. What we can do, simplification of dosing regimen is very important. Fixed dose combinations, in India it is available since last 2 decades. Now the Western world is talking about it. Recent guidelines, they are flooded with the fixed dose combinations. Then we should know which drugs are going to produce side effect, and it should be pocket friendly for the patient. This is one of the studies in which heart attack patient only 2/3 continued their treatment for 30 days, and 1/3 patient they left their 1 or 2 medicines. Now you can see only after 1 month of the heart attack. This is the scenario. Fixed dose combination, it has been studied both in abroad and in India also. Fixed dose combination is beneficial because there is a less pill burden, and probably we are using 2 drugs, so we are reducing the side effect also. And in the study of this Empire trial, which was studied in various countries, it was found that it is more efficacious than the single or usual care. Cadila has manufactured a polycap which contains antihypertensives, antiplatelet aspirin, a statin. This is the drug salicylic acid 100 mg, ramipril 5 mg, simvastatin and cholesterol lowering 20, atenolol and hydrochlorothiazide. All those except simvastatin, the bioavailability is the problem. But rest of the, whether it is a usual treatment or in the polycap, it is similar. And in the TIPS trial, it was found that polycap or the fixed dose combination of 4 drugs or 5 drugs is better than using the single drug. So what are the benefits? Whom we should pass it? It causes significant CV risk reduction. It improves the adherence and the compliance, which is a major hurdle on the part of the patient. It can reduce the side effect, and it is cost saving, pocket friendly. So it can be used widespread. Who can be benefited? As I mentioned, in primary prevention, in secondary prevention, both. It can be used in patients with hypertension and dyslipidemia. So in summary, fixed dose combination polypill, it can be used in the patient who are having chronic disease, especially coronary artery disease, with or without risk factors such as hypertension, dyslipidemia or diabetes mellitus. Risk factor requires early recognition and early tackling. Compliance is most important, which has emphasized. In this matter, polypill for effective control of multiple risk can be an ideal choice. This photograph was taken by me. There is a Firangi Pandit. He is practicing astrology. Astrology, I don't know whether you know or not. Ravan is the best astrologer, and he may be a demon, but he was the best astrologer of his time. So it is not that what India produces cannot be taken or accepted by Western world. And the same is true with the polycap also. As astrology, as a yoga, the polycap or the polypill has been accepted. It is effective, well tolerated, and it can be a solution for global use. Thank you very much.